This conference will now be recorded.
Hello, everyone. Welcome, and thank you for joining us for today's ACRM Pandemic Webinar, which is part of a series of webinars produced by ACRM and its community groups to help bring needed information to rehabilitation researchers and providers regarding the use of telehealth during the pandemic. My name is Tracy Wallace, and I am co-chair of the ACRM Pandemic Task Force, as well as the ACRM Technology Networking Group, which is the community group that came together with ACRM leadership during the early days of the pandemic to initiate this webinar series. And I'd like to personally invite those of you who are not already members to consider joining ACRM and the ACRM Technology Networking Group. Today's webinar will be presented by Nan Musson and is entitled Telehealth into the Home, Department of Veterans Affairs Experiences. But before we get started with the presentation, I do want to advise that this meeting is being recorded. I'd like to ask all attendees to keep your phones or mics muted and keep your cameras turned off throughout the presentation. We do expect to have about 20 minutes available for discussion at the end of the webinar. So if you have questions, please type them in the chat feature, and we will address as many of those as we can during the later part of the hour. And with that, it is my pleasure to introduce our guest speaker, Nan Musson, who is the National Speech Pathology Discipline Lead within the Rehabilitation and Prosthetics Services Program Office at the Department of Veterans Affairs. Her career as a speech-language pathologist began at the Miami VA Medical Center, and she served as the Section Chief, Speech Pathology Services in Gainesville, Florida until 2019. She is a fellow of the American Speech-Language Hearing Association and received honors from the Association of VA Speech-Language Pathologists. She is currently involved in developing several evidence-based intervention protocols using telehealth technology. Nan, we're very thankful to you for accepting our invitation to present, and we'll now turn the presentation over to you.
Thank you so much. I'm pleased and honored to be able to join you today and share some of the strategies we've been using in the VA healthcare system. For disclosures, just wanted to say that I am an employee of the VA, and I have been in the VA for about 30 years now. So I'm going to be covering issues related to VA and veterans populations. The veteran group is overall ranges from ages of about 17 years old all the way to our old populations into 104 and 106. So the VA often reaches out to across a wide variety of different ages, but I'm going to be covering topics related to adults. The objectives today I'm covering are basically touching bases on different strategies that we've used within the healthcare system in the VA and how you might be able to use them in your own practices or in your own healthcare settings. Just a special note that I'm using the word telehealth quite a bit. That's what we use in the VA system, but your individual practices may use the words telepractice, telerehabilitation, or telespeech in this case, or tele-OT, PT, etc. So follow your local facility recommendations and your professional organization recommendations. The healthcare transformation, as you all know, and transition started out that doctors were providing care in the home, and then we transitioned into doing care in hospitals and clinics, and nowadays everything is via technology. All of our record keeping, our coding, our billing, and our telehealth services that we provide. And technology is constantly expanding and developing. So what I may present to you today, we may have lots of new information next month. Historically in the VA, speech pathologists started using telehealth technology for communication disorders in the early 80s. And I give credit to the Birmingham VA, who did a cooperative study focused on TEL-C. And what that was telecommunication for individuals with aphasia. They used at that time speakerphones and fax machines and even touch tone phones, which most of you may not remember. But they used the touch tone on the phone to then be able to hear different response patterns if the patient wasn't verbal. Later along the line, Terry Wirtz and colleagues did reviews on how good was our ability to evaluate patients in a remote setting. So they compare live face-to-face scoring of different aphasia tools against observing on video conferencing. Later, we find things like microcomputing and telehealth treatment for different aphasia programs utilizing different technology. And I do want to mention our colleagues from DOD and Tripler, who initially started out with voice treatment from different DOD settings at Tripler out to different settings such as across Hawaii and out to the Philippines. They also initiated different telehealth activities for those with cognitive disorders as well. I do want to focus a little bit on one study that the VA had, and that was Lynn Tyndall Covert. And she really focused on the advantages of telehealth technology. So she looked at the mileage a patient would have to drive, time off from work if there was a spouse or caregiver, or if the patient had to take time off from work, time involved in the actual session itself, how much it might cost per visit, and then other related costs such as gas, etc. So she found that it was very cost effective to be able to utilize telehealth technology. And in her population, she was using the LOUD or the treatments for patients with Parkinson's, which I'm sure you're all familiar with, such as Lee Silverman voice therapy. She also highlighted the fact that we needed to look at the patient and the provider satisfaction and found high patient-provider satisfaction. And there will be an attachment on this recording that will include a sample of a satisfaction measure that you can use. Since COVID has hit and we've really increased our telehealth activities, we've had a 90% satisfaction rate with patients, and they really prefer getting their treatments rather than having to worry about traveling and exposures. I also just wanted to mention one other key aspect about telehealth is that we can utilize our 10 principles of rehabilitation, use it or lose it, actually using the technique, improve it, and in particular things like repetition matters, intensity matters, timing matters, and salience all play a role in doing our telehealth. And what we found is individuals that would frequently have cancellations or no-shows, they are actually showing for all their telehealth visits, or if by any chance they miss a telehealth visit, you can easily contact them and say, okay, let's link and do a telehealth visit now. So we're able to apply and use these principles across the board. The VA uses what we call an umbrella term, connected care. So it includes a wide range of different virtual technologies. So it may be a home device, it may be your cell phone, it might be an app or app monitoring device. And these are the big umbrella areas that we talk about. So one is clinical video telehealth into the clinic in particular. So you might have an outpatient clinic that you're reaching out to provide care, and their patient may actually be in a small clinic or a small urgent care area. Home telehealth, which is monitoring devices, Video Connect, which we'll touch on quite a bit today, and then Store and Forward, which is storing an image and then reading it or observing something later down the road. There's quite a few imaging opportunities with that, and not a lot in rehab yet, but I do see that that's going to be a future for speech pathology who may have swallow studies that are recorded in a radiology clinic, and you can review it in the future. Here's the key thing that we all have to keep in mind: providing the right care at the right place and the right time. And that's one of the things that we often forget. We get so focused on the technology and we forget about the things that are important to identifying what the best treatment is and at the right time to provide to the particular case that we're going to be treating. So my theme is always say who, what, when, where, and why, and then determine how you're going to do it. So be very clear on the patient population, what you want to actually provide on that telehealth visit, when you want to do it, where you want to do it, and why. When right now is very important because we have many patients that might be at home with sharing computers or technology with kids at home that are trying to do school, and we need to be flexible on when we are providing that care. So we might have to extend some of our hours or change our schedule so that we might be treating a patient at 6 in the morning or 6 at night instead of our usual 1 o'clock time. You always want to remember that you do the same high quality care that you would in face-to-face appointments. A lot of people, again, get worried about the technology, but you want to focus on what is it that you do currently in your practice and then apply it using different modalities. Always follow your best practice or your evidence-based practice for your discipline. I just listed the American Speech Language Hearing Association evidence-based map here, but every different discipline does have evidence-based protocols and evidence-based literature available, and I do have a few of those attached at the end. We also can use the benefit of telehealth when we coordinate services. So we might be able to do a home visit with a nurse in the home, and the speech or OT or PT or coordinating care, maybe at their medical center or even if you're at home. And then also keep in mind continuous care. So once you, for example, have issued a treatment device or adaptive device in the home, use this opportunity to then be able to go back and follow up and check on that patient in the home, make sure they're using it correctly, frequently, etc. Speech pathologists do a whole range of different activities, everything from vocal cord and voice treatments to cognitive rehab and swallowing rehab. This is just a quick slide to remind us that we have lots of different areas that each of our disciplines may treat. And so our group that initially started working on telehealth activities divided up major diagnostic categories and then started looking at could we provide evaluation, treatment, and counseling via telehealth, and what might we need to be able to do that. Some activities we might not be able to do by telehealth. So for example, stroboscopy we may not be able to provide using telehealth technology in the home. We might be able to do it if it's in a clinic. So it just depends on each of your different areas and what tools you might need to do it. Also, we did kind of a quick checklist to find out, do we need an assistant in the room? And so we just made notes about what type of task where you might want someone else in the room. And that can be any number of different people. It can be a nurse, it can be a family member, it can be a paid caregiver that you want to have available in the room when you're seeing the patient. This is just a funny picture to show you can do even very complex tasks and do something like a cranial nerve exam during oral motor. This is using a large screen, and that's another aspect when you start thinking about your technology. How big of a screen do you want for you and or on the patient side? Things to consider for telehealth are, how far does the patient have to travel? Is it safe for them to travel? We all know we have patients where they aren't safe to drive, so telehealth may be very, very important role and part in their care. How much time and the cost, which we touched on earlier. The physical toll on the veteran or the caregiver to get back and forth to your clinic appointments. It may be a private office or it could be a medical center, and all the parking and things that they have to do to plan to get to that appointment. And often you might only see a patient for 30 minutes. So if you think about all the stress that they have to do to find a parking spot and then get into a medical center, it really is a consideration to using telehealth. Does the patient fatigue very easily? Did they no-show for clinic appointments? With a lot of our mild traumatic brain injury cases or PTSD cases tend to have frequent no-shows, and we found that just touching bases with them once a week by telehealth, we're actually able to see them more frequently. Weather, in Florida, we have to worry about hurricanes, and those up north have snowstorms. And then think about veterans that are in rural areas too. This is just a quick picture of all the range of areas that we reach out to within the VA system. So we might have someone that is actually in Pittsburgh and they have an ALS patient that is in the Philippines. So you can reach out to telehealth across many different areas of the country. I'm just going to give you a quick perspective. When I started telehealth, I live in Florida, in Gainesville. Yes, go Gators. And then my catchment area for our healthcare system is in the red here. So we started first by looking at different areas and the different populations in the catchment area. So, for example, in Jacksonville, Florida, we had a lot of very young veterans that were being discharged from the Navy. And so they were very familiar with technology, and more frequent to use telephones, smartphones, and computer technology to be able to communicate. Sorry, I don't know why that keeps shifting there. And so then we looked at the villages, which is very much a retirement area of the country, and we have lots of snowbirds that live there. They may be down in Florida for 6 months and then go back up north. And so we did set up telehealth clinics in that actual clinic, and you can get a snapshot there of us connecting then with providers locally at that clinic where we could see them. And then we could remote with them later down the road back to their home or facility back up north. I'm just going to quickly go through some lessons learned and share some examples that we have in the VA. So setting the stage for a successful appointment. One very important thing to do is to develop your pre-flight checklist. So think about all the things the airline stewardess and pilots do to get started. before we take off. And what you want to think about is be prepared for anything that could go wrong and have a strategy in place. So for example, safety. You want to know where the patient is. Are they at home? Are they at work? Are they at school? Do they have a quiet place to sit? And that's private and away from noise. And I'll give an example that one of our clinicians shared the other day, that they actually had a patient that was driving, and they had to tell them to please stop driving and pay attention while you're doing your telehealth visit. Know the 911 or your emergency contacts, someone close by. In the VA, we're very conscious of suicide prevention, and so have any of that information available at your fingertip. And then have a backup number in case anything fails during your telehealth visit. So if the power goes out, if you lose connectivity, anything like that, that you're ready and prepared to still contact that patient and stay in reach with them. And then the clinician checking everything to make sure your equipment's working, that you have good visual field, you check your view, your lighting, etc. One thing is that you have to remember, since we aren't right there with the patient, we're generally a 2D picture. And so we have to make sure that our positioning and our pragmatics and our eye contacts are all meaningful to them. Don't sit too far back, don't sit too close, look natural as you're moving your hands. Materials, what type of materials and equipment do you need? Make sure they have all of that in advance, and cross-check before you start your appointment with them. Because if they don't have everything that you need them to have, you might need to change your appointment or change the approach that you're using during that actual appointment. We always recommend that you do a test call even before you start your treatments with the patient. That way they can feel comfortable with connecting in the environment, etc., know how to run all their controls. And even today, I did a practice session with Terry just to make sure I knew where everything was. And so every time you work with a patient, you want to make sure you try that first. Don't expect your first treatment session or your evaluation session to be perfect if you haven't practiced a few things. And then use other types of tools like a fax machine, snail mail, email, to make sure patients have any materials that you might be sharing with them, as far as maybe a written test or educational materials, etc. In your documentation, in the VA, we always recommend a checklist. So we check off that we have done all of the pre-flight information, and we have that in our records, that we've actually got it in case there's any type of change or emergency. I'm going to touch bases briefly on technology, and it can be wide and varied, from a very specific telehealth technology, such as a DX90 or EX80. There is also the HITT, which is that little device with the 2 antennas on it that has the option to sit in a patient's room. If they don't have the ability to move around, they can put it on a table and keep it steady. And then, of course, there's our traditional desktop, laptop, iPad, etc. This slide may be a little small for you to be able to see, but one of the things that we spent some time doing was kind of drafting out what would be the appropriate modality for each type of patient population we were seeing. So you may have a young person that you're working with that is a whiz with an iPad, but on the other hand, you might have an older individual that needs a more stable computer that's on a desk, and they can control the tablet, the keypad, without a lot of problems. And then we also, because we're all in rehab, have many different challenges we have to overcome, such as hearing problems or vision problems. You might want them to do writing tasks or use an app. And the picture on your right shows an example of where the lighting is a little bit off and you can't see your equipment. So that might be an example of a pre-test where you talk to the patient about positioning or pulling the curtain down behind so that you can see the equipment or the device better. The two most common things that we found helpful are headsets or headphones for patients with a microphone so their hands are free, also for the clinician side as well. And then an Elmo document reader, in particular for speech pathology, we can put either written material that then can be viewed by the patient, or we can use devices. So, for example, if you're trying to show a patient how to use a augmentative communication device or a smartphone with a certain app, you can put that device right under it and it can display on the patient side so they can practice with you and you can go step by step. So screen sharing and Elmo document readers are two important options, in particular for psychology, speech pathology, anyone showing a lot of different materials or equipment. And think ahead too, because there's lots of easy tutorials and YouTube demos available that you can send to a patient in advance if you're going to be teaching them about a particular app or how to use different software on your phone. So this is just an example of different things we've used and shared. I mentioned the background and the lighting on this particular patient. They're doing the LSVT voice treatment program, and some extra supplies that they found they needed the patient to have were a sound level meter and maybe a stopwatch during that session. So think about equipment that you might need to send the patient in advance. When you're thinking about telehealth, or if you already have one in your healthcare system or within your practice, make sure you think about webcam sharing, screen sharing, and different interactive features that might be available. And there's different ways to research and look those up. With each system, there's pluses and minuses. And you may choose different platforms for different patients based upon their skills, or if you're doing individual versus group. I laugh because we all have done Zoom meetings and conferences with our families and staff, I'm sure. And right now, there is the chance to have Zoom bombs along the way. Remember that you still have to follow all HIPAA guidelines. Any transmission should be encrypted. Follow any state laws or relevant laws in your area. Just like your personal practice, you need to maintain all your client privacy. So think about that with your emails and any of your documents. Several people have also recommended that you may want to have a separate email so that you're not using your private email. And in some cases, you may not want to use your business email as well. These are just a few that the VA has determined that they think are a little bit more compliant than others, and some not to use. And I want to say this is not an endorsement of any of these platforms, and there could be changes, but this is just what we've reviewed so far. So I think everyone would know not to use Twitch or TikTok when you're working with a patient. The other consideration is your healthcare partner. So are you going to have a nurse, OT, PT assistant, a spouse, a family member, or even a vendor? So at the top of the screen, we're using a provider to help out. So a provider that was in another clinic. And at the bottom, the screen that you're going to see, the speech pathologist is standing and then working with someone on an augmentative communication device with the vendor in green, and then an expert on assistive technology is on the screen. So you can see that you can often have different providers and vendors or representatives available to do different devices. And there are quite a few of the augmentative companies right now are sending out guidance, and will do follow-up telehealth conferences with patients and providers due to COVID. Any questionnaires that you want to have the patient fill out in advance, make sure you send them ahead of time. And this is an example of using a provider to help with a pain module that we developed for mild TBI and musculoskeletal problems, where we had demos and actually sent video clips to providers to show them how to do these. So you can develop your own video clips or step-by-step how-to send out to a provider or to a caregiver in advance. With COVID, we've had a lot of need to do inpatient care, so I just wanted to mention that, in particular for social distancing and to save our PPE or preserve it as much as possible. So you will find that you can put different iPads or tablets into the medical centers as well on your intensive care units or in your senior center living facilities. We call it community living center in the VA. And we've even done a lot on COVID units recently. So for patients that need an evaluation, in particular on swallowing. But also, don't forget, telehealth is very helpful for domiciliaries and nursing homes, state nursing homes, assisted living facilities, and medical foster homes as well. One thing that we found helpful and fun is respiratory therapy, working together. So the respiratory therapist may be at bedside and then the speech pathologist observing. The other option is to think about our poor patients that are not getting stimulation in these care centers or nursing centers because they're restricted, having visitors, etc. So it's often helpful to work with the nurse, or in a couple of cases, we've had recreation therapists that are in the facility, and we've done joint sessions and group sessions that way. We had our Minneapolis VA develop steps for how to do iPads and monitoring and keeping in mind safety and privacy and security. So they have set up a couple of different options for how to do that. You can see that they've mounted the tablet onto a plain old IV cart so that it's easy to roll around. And then they've configured it so that the speech pathologist has got bed 1, bed 2, bed 3, then they can connect with the patient directly without having to have the nurse in the room to have to set things up for them. When you're using different devices, in particular on an inpatient unit, make sure that you have a cleaning process in place. This is just an example of the steps that we've recommended, but with COVID, and if you're using it on a COVID unit, you might have to have extra bags or coverings. A lot of places are just using a clear paper bag or plastic bag over the tablet when they're have a patient using it. We have had a home interdisciplinary rehab team that was coordinated and piloted at Des Moines VA. With that team, we had the OT, PT, and speech pathologist at the medical center, and then the home care nurse took a tablet out to the home and worked with the patients. And we found a lot of information by doing that, together as a team, but also you could see the actual environment that the patient was in, discuss the patient and the family needs. It reduces the caregiver burden and gives them the opportunity to say what really the issues are, what's bothering them the most, what can we help them with the most. Again, the intensity and frequency. And you can revise the plan of care with your team in real time. The link for those training modules is on a site with the University of Pittsburgh, and I have that included there, so you can go in at any time and look at some of those video clips. And these are just two quick observations or video clips that we have on there, and I'm sorry, we can't play the whole video clip right now, but at least gives you an idea that you can actually see, okay, what does that kitchen look like? What's the safety like? How do they sequence getting things out of the refrigerator? And how do they compensate for maybe a hemiparesis? And so you actually are able to see it during real time. The Pittsburgh VA has been the leader in an intensive aphasia rehab treatment program called the Pirate. One of their issues was they bring patients in for 6 weeks of intensive rehab. But as you can tell, that probably is limiting because patients can't afford to move to another facility for that long for many reasons. And on average, when they were reviewing how many sessions patients were getting without the intensive rehab, they were only getting about 12 hours total of rehab. As you all in rehab know, there's always a push to hurry up and get somebody discharged. So you might have someone with a very severe aphasia. 12 hours of rehab is not going to be enough. So they worked out a program where they have saved different types of materials on a SharePoint, and then the patient uses actually 2 different devices. So they're using a tablet and they have the telehealth visual equipment. So they're able to do then auditory, verbal tasks, gesturing, writing, drawing, and be able to do all different communication modalities in a single session. The DOD and VA also have developed management guidelines for stroke and have a stroke program. And so individuals that might be in rural settings are able to meet with a neurologist via telehealth. And we've just added a component of speech pathology, doing swallow screenings to determine if the patient is able to eat and drink or take their medications before admission to the hospital. So it's actually in the ICU or in the ER for making a decision about continuing. What we found is we don't have speech pathologists in all the rural areas, and we don't always have a speech pathologist on site during the weekends. And so this has been a really helpful option available. Also, the other group that we found didn't always get a lot of treatment. A patient might be diagnosed with dysphagia, but on average, they may have only gotten 3.9 sessions in before they left the medical center. So telehealth has been very helpful for that, and we paired that with an intensive dysphagia treatment, which is 8 weeks, and it was initiated at the Madison VA, but we now have it at 18 different VAs across the country. So we use different feedback devices that can help with strengthening, and so there are fewer pictured there, but they were devices selected to make sure that they could give feedback to the patient and they could help record different task and how frequently they did and how well they did on those tasks. So you can pair up a device that may monitor outcomes while you are doing your telehealth. And so you might only have to check on a patient twice a week instead of 5 times a week if they're following through with their exercises and following their goals and targets. The other thing that we have initiated is a organ preservation program. As we know, there are older veterans who were chronic smokers and had lots of exposures to things that may have been risk factors for head and neck cancer. But now we're finding we have the younger populations as well with the HPV virus. And so they are undergoing different radiation and chemotherapy treatments. When they are getting radiation therapy, there are lots of side effects, and it can be very long-term changes in oral, motor, and swallow function. And so one of the things that we found telehealth extremely helpful for is to use telehealth for that. It allows us to be able to track patients during their treatments, make sure they're doing their exercises, even if they have a G-tube or a feeding tube, and we are able to monitor for any kind of changes like mucositis or yeast infections, and monitor for any kind of weight loss or dehydration. The other nice thing, if you have the device for a smartphone or tablet or computer in the home, you can actually have a meal with the patient. So you can have them set up and you can watch them eat and see how they're doing, and if they're following through with the exercises, how they're doing with their hydration and their calorie intake. This is a very complex telehealth mentoring program we have, where a patient might be at a medical center that only has radiology and not a speech pathologist. So the radiologist would be filming, and then the speech pathologist would be at a medical center reviewing real time while it's going on. The other thing we have used for this is new clinicians that need to have competency checklists. We've utilized this technology as well to be able to watch real time and then give feedback on how the study is and if there's any other strategies that we might recommend while the study is going on live. I mentioned assistive technology earlier, and these are the major areas of assistive technology that we address in the VA. So it's important to think about how can you partner with other people that may be an expert in a certain area. So for example, I may have a stroke patient that has aphasia, but I know nothing about sports or recreational things for a patient. So I might call Richmond and say, let's work with this patient together and find out what might be the best adaptive devices or options for this patient. Cognitive rehab, of course, is something that is a high volume for us in the VA with mild traumatic brain injury. And I just wanted to mention that we do have the cognitive rehab for service members and veterans that is available to anyone, any clinician. It does provide guidance on cognitive rehab and considerations. And I would recommend clinicians working with that population to take advantage of that. The VA also has app stores, and this also is open to the public. They're open source, so take a minute to go into those app stores. They do have a lot of apps that might be helpful to your patient populations. For example, we have a concussion coach. We have a PTSD coach, and there are some different coaches and apps for mental health right now, which is important because so many of our patients may be experiencing fear and anxiety like the rest of us, and they have a variety of options to be able to share with your patients. Many of them are designed and have very nice educational materials in them too, and you might find them helpful for other populations that you're working with. The other thing is My Healthy Vet, and I don't mean to be, promoting everything VA, although I'm a part of the VA, but one thing to think about is your email system and to make sure it's secured. Facilities and other healthcare systems, you may have your own email system. One thing that speech pathology has been using it for is to journal, and so journal and maintain different activities during the day, or if you say, I need you to do this exercise 4 times a day, 3 times each, then you can have the patient track and tell what they're doing, or they can journal different problems that they're having so that they can discuss with you. Also maintaining nutrition information, what they're eating, their caloric intake, weights, and any kind of home exercise program you're giving them. Also text messaging. Don't forget to think about text as a virtual opportunity too, reminding patients to do things, follow up care, are you having any problems, and to reach back to you. And then competency checklist, I just wanted to mention that within your facilities, you may need to have a professional competency, which are your knowledge and skill base for your profession, as well as a telehealth competency, which is more technical, how to do a telehealth visit, all the steps I have to do. That will be also included in the attachments when we send it to you. Insurance and regulations and licensure is different, and I won't have time to cover all those different aspects today, but I do want to remind everybody to check with your local licensure. There are specific rules for providing telehealth services within different states around the country. I know that all of our professional organizations are working on that, and CMS has relaxed what we can do via telehealth. So stay tuned. It is constantly changing. And Centers for Medicare and Medicaid Services have also relaxed and are starting to allow some opportunities to bill for telehealth services. So again, I recommend you check not only your professional websites, but also CMS. ASHA is very good, which is the American Speech Language Hearing Association, about posting reimbursement issues regularly. So for the speech pathologists, I recommend you check that periodically. And they do have a lot of telepractice resources and information about state policies. So they have graphs and charts indicating which states and what you can do in each state. I've also added on here the link for the American Occupational Therapy Association and their emphasis on different types of treatments, and the American Physical Therapy Association. So that's available in the slides. And I'm almost getting ready to wrap up here, but I do want to remind everybody this is Better Speech and Hearing Month, or Better Hearing and Speech Month. Communication is very basic and very important to how we all interact with each other, either in person or with a mask on or via telehealth. And that's one of the things that telehealth has really been an advantage. I know when I mentioned inpatients, I didn't really say this, but patients are appreciating being able to see your face via telehealth rather than someone with a mask where maybe they can't hear it or they can't see your face. Where telehealth, you can actually see their expressions. So I'll pause here for any questions and turn it back to our ACRM staff here.
Thank you, Nan. Thank you so much for sharing your expertise. It was a truly wonderful presentation, really just excellent. I found it very, very comprehensive, and can't believe you were able to share all of that in the amount of time that you did. So thank you. I see that we do already have a question. The question is, or the comment is, that it seems that the VA embraced telehealth long before the pandemic. Has the pandemic caused the VA to put additional emphasis on its telehealth services? And does the VA now prefer telehealth for certain types of services over traditional in-person visits?
That's a great question, and yes. We initially started telehealth from clinic to clinic. So in the hospital setting, we would reach out to our small outpatient clinics into rural areas, and that's how we got started. As the pandemic has hit, we've used telehealth in a whole wide range, as you can see, of different areas. And absolutely, I think what we're going to find is clinicians are using it as an ongoing and regular part of their daily activities. I was surprised when we looked at some of our data that really our number of visits with patients has not dropped off that significantly. We're still providing outpatient care using telehealth technology, and we've expanded to the inpatient setting, which we never thought would happen. I do see that it's going to sustain itself. I think there's common techniques that we all do in our practice that might be visits that are short visits, or education or counseling that we can do on a regular basis. So yes, I think it's going to be here to stay. I know I was watching a program with Bill Gates talking, and he said, 15 years ago, we would not have this opportunity, but now with everybody having some technology, even if it's just this phone, that we can all reach out and communicate with each other. And I'm sure you're all doing that in your own personal lives too, having more calls with families via telehealth.
Well, yeah, that's such a great point, how much technology really has afforded us these opportunities now. And it's so interesting to hear too about how something not so great, such as the pandemic, has led to some positive things in terms of accelerating telehealth delivery, and that we're maybe finding that there are some situations where that might be desired even in a situation where we're not in a pandemic. So really interesting. We don't have any other questions in the chat feature right now, but we do have a little bit of time left. So I'm going to ask a question here myself, but I'd like to encourage anybody listening that has a thought, a comment, or a question to please do share in the chat feature while I'm asking Nan my question. And so, Nan, I wanted to ask you if you have any thoughts about delivery of group therapy that is a blend of in-person and telehealth, so that perhaps some group members are present while others are participating online. I am hearing people talk about this as a possible service delivery method in some outpatient clinics in order to meet social distancing needs. What are your thoughts about that?
I think that's great. We have a good example, again, with LSVT. I don't want to pick on that, but I know a lot of different disciplines use that same principle with loud or big. And so it's something that you can do in group settings. I think the key is to set your rules. So if you have someone that you're seeing in person and doing it also on telehealth, let's say in a Zoom type setup, that you want to make sure that you're directing your eye contact and your attention to the other group members using telehealth and not just pay attention to the person in the room. Some clinicians have talked about strategies for being able to do different group activities, and you do have to have rules if you're going to have different people on. So you might have somebody raise their hand, or you might give each person a number or a letter and call on that number or that letter to be able to give each person their own time, so you're not neglecting one person or one person taking over, and things like being polite. But I know a lot of clinicians have found it very helpful because you use it as a feedback mechanism as well. So just like an in-person group, you can use that as a strategy for each other to say, hey, you did that really well, or I didn't hear you, or speak up, or whatever the task is. So I did have one population I really didn't talk about a lot, but we've also have a lot of laryngectomy patients in the VA that we've been social distancing by making sure they have all their supplies available at home. So if they have a puncture, a tracheoesophageal puncture, and they're using a prosthesis, we've been mailing them out supplies like plugs and catheters and all of that. So in case they have a problem at home, they can be able to try and fix it or at least plug it up so there isn't a major problem. And so that's one very unique population that we've been able to do and get. They might have to really take their neck and put their stoma right up to the screen to be able to see it, and give them instructions on what to do as far as their cleaning or how to drink liquids or protect themselves. But that is one population with COVID that we found telehealth to be helpful too. They're used to coming in to get their supplies or change things, and we need to all be mindful of social distancing with them as well.
Oh, some really great tips. Well, thank you again, Nan, for sharing your expertise with us. This was just so informative and so very needed. So I really, really appreciate you speaking with us and sharing this today. I want to thank also everyone that's listening. We appreciate you attending and invite you to attend future webinars. This recording will be available in the next 24 to 48 hours, so please check it out. There will be a couple of documents attached with the recording. As Nan mentioned, she is sharing some very helpful information. One is a sample of a satisfaction measure that can be used to evaluate patient satisfaction with telehealth services, as well as a sample competency for training staff for telehealth and the use of the technology. Please do consider recommending this webinar series to your colleagues. And this concludes our episode for today. Be safe and stay healthy, everyone. We hope you will come back and join us again at the next webinar.